All right, good morning. Welcome to our COPD lecture. Okay, so not so fun fact about COPD, it is the fourth leading cause of death in the United States. All right, there's some current changes in the way that they diagnose it right now, and it used to be that we broke it down into two separate entities, or two separate subtypes of COPD, and those are chronic bronchitis, right? So this is the old stuff. So chronic bronchitis or emphysema, okay? But they quickly found out that nobody fit really into those categories. The characteristics or requirements, diagnostic, whatever, the way that the categories worked, not one patient fit into those categories. And so most patients will have different aspects of chronic bronchitis and emphysema, and so that's why they just decided to call it just COPD, okay? So we have just COPD and everybody's in one category. They're all chronic obstructive pulmonary disease. And so it has to do with the complex structure defects in their lungs themselves, and that's what defines COPD. So you have structure defects in the lungs themselves, but what is the actual histology tissue of the lungs that's damaged? It's the parenchyma. Okay, and then we have our small airways, as you know, are damaged. Okay, so we got chronic bronchitis emphysema. That's the old way to do it. No one fit into either one of those categories, so we renamed them. And then there's a new subtype referred to as asthma COPD overlap. Okay, and that's kind of a newer thing. It has to do with early onset asthma, less than age 40, and then usually they all have a history of smoke exposure or other sort of noxious fumes. Okay, so let's go straight to the risk factors. So I'm just going to move through these really quickly because I want to move to what COPD looks like and how we're going to treat it. All right, so some of our risk factors are, well, okay, number one, the obvious one, they smoke tobacco or marijuana, okay? So they either smoke tobacco or marijuana. All right, then we got secondhand smoke. Okay, and then they usually have a history of frequent respiratory infections, right? Okay, usually as a kid, and then they have some sort of impaired lung development, whether in utero or whether they were born too early. There's all sorts of ways you can mess up the development of your lungs. Then we have pollution. Then we can't forget our workplace exposure. Okay, and then advancing age, obviously, is a risk factor, and then our history of reactive airway disease / asthma. Okay, so if you already have a history of asthma or some sort of type of reactive airway disease, then you're more susceptible to chronic bronchitis, or sorry, see, I even did it, to COPD. Okay, so we're going to talk about exacerbations here in a second, so we'll get back to that. Our subjective symptoms, so what does subjective mean? Remember, that's what the patient reports to you. Objective is what you can hear, feel, touch with your own observations, right? That's your assessment. So the subjective signs and symptoms that they complain of, well, the number one thing is increasing dyspnea. That's a very common complaint. It's usually persistent and can be progressive over a period of time. So obviously dyspnea is not a symptom that is isolated only to COPD. So just dyspnea by itself needs to be further investigated. But these are just common symptoms that people complain of. And then cough. It's usually a productive cough, right? They're always coughing up something. It can be dry, however. So then we're going to talk about our, is it chronic or acute? Which one is it? So obviously it's chronic obstructive pulmonary disease, so the definition is right there. So it does tend to be chronic, right? Okay, then we talk about what we can see, hear, touch, feel, right, as part of our assessment. So what do their lung sounds like? What do they sound like when you hear them with your stethoscope? So we got some breath sounds that are, you can have decreased breath sounds, right? So we got some decreased breath sounds. We also have wheezes that you can hear. And then also we can have crackles in the bases. And then we have a prolonged, is it a prolonged inspiration or a prolonged expiration? So do they have a hard time getting air out or a hard time getting air in? It's usually expiration. They can't get their air out, okay? So usually you'll also have, because of the buildup of fluid and other sort of scarring or whatever is in the way, now when you try to listen to heart sounds, they develop, as the disease progresses, the heart sounds become more distant because you're trying to hear those heart sounds through, you know, inflammation, mucus, scarring, all that kind of stuff, okay? This is kind of an old school thing, but it's still really, actually really helpful assessment tool, and that's percussion. So we usually, when we percuss someone with COPD that's classic, you'll hear an increase in resonance. And that has to do with the physiologic changes in their chest wall and their chest cavity itself, and also right with the air trapping. Okay, so we're going to talk about what it looks like, and we'll get into that. Okay, so what does a COPD exacerbation look like in the ER? Okay, so we're talking about emergently, these people are having an exacerbation bad enough that they show up to the ER. So I'm not talking about the chronic management of COPD or COPD as it would present in an office. We're talking about people that are in acute distress with their COPD and now they're coming to the ER, okay? So in an exacerbation, usually the causative organism, it can be bacterial or viral, but it usually starts out with a cold virus, okay? And the important part about this is to get a really good clinical picture. So that means I need a good history. So you need to ask them questions like, hey, you know, when did this start? And what were your symptoms when it started out? They might say, well, you know, for the first 4 or 5 days, it was just some cold symptoms and my cough got a little bit worse. And then by day 6 or 7, if it was a normal individual, they should be starting to kick that cold. And the virus population is just starting to be declining. And they should be feeling slightly better. With our COPD folks, the opposite will often happen. Not always, but will often happen where they get a cold virus or whatever, and then by day 4 or 5, when they should start to be kind of sort of kicking it a little bit, and especially at least by day 6 or 7, they should be feeling better, they get dramatically worse, or there's a change in their cough, increase in sputum, you know, they might have some associated more difficulty breathing, things like that, more wheezing, changes in their breath sounds. And so that will usually happen. Instead of them getting better, they get worse. Okay? So let's talk about what does it look like in the ER? So these people usually come in, they're pretty sick. They're tough individuals and they'll come in after it's been going on for a little while, right? So we talk about AP and lateral ratio, and that is what changes in their physiological structure, okay? So, all right, so we got some changes in the chest cavity itself. So we're talking about the actual structural changes, okay, and why they look the way they do. So we have an AP lateral ratio change, okay? So our normal AP lateral ratio in our chest should be 1 to 2, okay? So if you don't know what AP to lateral ratio is, that is, so if I draw a bird's eye view of chest cavity, if we're doing, if we're looking, you know, down into the patient, kind of a cross section, then our AP is our anterior to posterior. That's our distance from the front to the back, right? And then our lateral is from side to side. Right? So does everybody agree that we should be twice as wide as we are thick? So the distance from the front to the back should be 1/2 the distance from side to side. So a 1:2 ratio. Okay, now with COPD, this changes. This ratio completely changes to where now we look a little bit more like that. And now what's happened? Well, guess what? We're kind of more like a barrel now. And so now that ratio, where it should be 1:2, it's now equal, or more or less equal. So it's now 1:1, and we get the, I already said it, we get the barrel chest, okay? And then what's actually being remodeled is the ribs, our ribs and cartilage are now being remodeled because of the increase in air volume, okay? So why, and now let's talk about why this happens. Well, you have a constant hyperinflation, remember? So they can't get rid of their air. And then due to, why is that? Well, because of air trapping. Okay. Okay, so what are these guys, other than what's going on underneath, what do they look like? What's the color of their skin? So color of their skin tends to be not nice and pink when they're having an exacerbation. They're usually cyanotic. So these are the folks that are in an acute exacerbation, okay? And then their position. Do you think they are laying flat? Do you think they are leaning back in a chair? No. They're doing what's called the tripod, remember, where they stick their elbows on their knees and they lean as far forward as they can. That's called the tripod. So they're tripoding, and depending on what is going on with you, you know, anyone in acute respiratory distress, because that's basically what's happening with an exacerbation, anyone in acute respiratory distress will compensate that way. You will sit down, you'll lean forward, and you'll tripod yourself on your knees. So that's usually a human instinct and something to be observed for all respiratory distress. Then their neck hyperextends, right? Remember? So what happens if we hyperextend our neck? Well, we hyperextend our neck. Now we've opened up a little bit extra lung volume here on top. So if we can kind of hyperextend our neck, push our chest around this way, we can open up a little bit of extra lung volume that way. And that's kind of a basic survival instinct as well that people will do. Okay, now a lot of people talk about nail clubbing, but recent research and literature is now saying that nail clubbing is not COPD, but usually is indicative of another pathology. So COPD is one of the signs and symptoms or common physical characteristics clubbing is not considered a common characteristic of COPD, but some sort of other underlying pathology that you need to investigate further, okay? So now let's talk about our pathophysiology of COPD. So we have our normal alveoli and we have COPD alveoli. And I'm going to pause the video and we're going to talk about the difference between a Ziploc bag and a shopping bag. Pause the video.